will we need to push any of these buttons?
I think it should be good to go, sir. Yep,
Okay.
you just keep it on.
Oh, okay.
Okay. Gentlemen, you ready? All right. Good morning. My name is Akeem Ashford. I serve as your Director of Strategic Communications here at Sedgwick County Government. I want to first thank Dr. Mins, Dean of KU School of Medicine, Wichita, and Sedgwick County Health Local Officer. Dr. Sam Antonios, Chief Medical Officer, Ascension Via Christi Hospitals, Wichita, and Dr. Lowell Ebersol, Wesley's Chief Medical Officer. They are here in their own time to give insight and information related to COVID-19 and the path moving forward. This is a virtual town hall. You are joining us on Facebook. We are having some technical difficulties with YouTube, but we are also recording this live. So once this is finished, we will post that on each of those social media channels. Our doctors are socially distanced with plexiglass between them for current situations. We gathered a list of these questions from an online post on the county's Facebook and Twitter pages, so I will be sure to gather as many of them as we can today. If you are watching live, there is still time for you to ask questions of COVID-19 related only. Please provide those in either the Facebook live chat window below. We will take as few of those questions from the live event today to be sure we get to as many questions as possible. To begin, we will allow Dr. Mins to begin with just a quick brief introduction, if you'd like, sir, to the folks that are watching.
So I appreciate everyone's interest who are listening in. I think it's important for us to hear what the questions are by the community and help to answer those as best we can. So we look forward to this presentation.
Thank you. Dr. Antonios?
Yes, thank you for having us today here. And again, hopefully we can help answer some of the questions that people have on their minds.
Wonderful. Thank you, sir. Dr. Ebersol?
Yes, definitely appreciate the invitation as well, and happy to try and answer questions for the public and keep them at peace and at ease a little bit through this forum this morning.
Wonderful. Thank you, sir. Thank you guys again for your time. We ask that you refrain from negative comments and keep the discussion surrounding COVID-19. So let's get started. Doctors, I'll ask a series of questions. If one of you want to chime in to answer that question, feel free to do so at any time. Question 1, is the saliva test as accurate as the nasal test? What's the point of testing if there is a high false negative? How accurate is the saliva test?
I'll try and answer that one. The first test that came out was the nasopharyngeal test, and that's the one that we have the most data about, the most proof that it's very accurate. There have been studies done on saliva, and it appears that saliva contains quite a bit of the virus. We have just received permission from the FDA to initiate some saliva tests, and there is an agency in Kansas that is doing that currently. We think the saliva is probably going to be as good as the nasopharyngeal, but we probably need to see a little bit more data on that before we can be sure about that. But if it indeed turns out to be as accurate as the nasopharyngeal, it would be a great way to collect specimens because it would be much simpler.
Wonderful. Thank you, sir. Can you talk about the difference between masks and face shields and give medical perspective on what's appropriate?
I can just talk briefly about this. When we're talking about masks, there's obviously several kinds of masks, and it's what you see people wearing most of the time. So it's a covering over the mouth and nose. There are medical grade ones. Those are that mostly are utilized in the hospitals. They have different level of blocking. And you've heard probably of something called an N95. There's also surgical masks, and there's regular masks that people have worn. The intent there is to prevent droplets, and droplets specifically that contain a virus, from being coming out or spewed out when someone is speaking or sneezing or talking. A face shield is what you have potentially seen people wear is typically a piece of plexiglass or covering that covers around the whole face, made out of plastic or something else. The intent there is potentially also to protect some of the droplets to go out. That's still some of the benefit, but mostly it's to also prevent from people from receiving onto their face droplets or secretions from surrounding people who are talking around them or sneezing. We use that a lot in the hospital, specifically within our units where we take care of COVID-19 patients, because you want to minimize as much as you can the droplets that contain the virus from coming to the face of a caregiver. We haven't really seen a lot of people wear that in the community, although that's potentially a possibility. In the hospitals, though, just to clarify, we typically have caregivers wear medical grade masks, and on top of it, most of the time they're having a face shield. That's the difference between the two. So definitely in the public, what has been recommended is to wear a face mask. That the wearing a face shield hasn't necessarily come out as a general recommendation, although there's really nothing that would prohibit necessarily a face shield from people if they wanted to wear a face shield.
Wonderful.
I would just add to that definitely agree with Dr. Antonios in regards to the face shields for the general public. CDC's doesn't have any specific recommendations around this for or against. There are specific populations that they would, where a face mask would not be an ideal situation for someone that may be hearing impaired or deaf. And so, utilizing a face shield so that lip reading can be done and still protecting that individual to some degree. But in the hospital, they're really utilized to protect our healthcare workers, as Dr. Antonios was saying, also protects the mask. If there could be certainly some fluids that were, in a surgical procedure or other type of procedure that could get on and be grade 3 N95 masks that we do a lot to make sure we protect and for the safety of our healthcare workers. So really just overall that universal masking, both in the public has been shown to have such an extensive positive effect. And then as we look at research within the hospital that, where Dr. Antonios and I live on a day-to-day basis, if universal masking is followed, the possible spread of COVID-19 within the hospital is exceedingly rare and low, almost approaching 0% if that universal masking is followed 100% of the time.
Thank you, Dr. Ebersol.
I might add that we have pretty good evidence, really good evidence, that the face masks do reduce the likelihood of transmitting it. There is good evidence on that. If a community was only use face shields, we don't have any good evidence that it really suppresses the spread of the virus. So I want people to know that mask, we have good evidence it's effective. We would not consider the face shield as a substitute for the whole population. But in the hospital setting, that's a different situation.
Yes, sir. And not to belabor that point, but as you guys know, there are many folks who don't agree with the face masks. So one question that came in is, can you come up with an expiration date for the mask mandate?
The metrics we look at to see how prevalent the community spread is multifactorial. We look at the hospital admissions, how many people are in the hospital with it, how many are in the ICUs. We also look at the number of people who are getting tested and what percentage of those people getting tested have a positive test, as well as the number of illnesses in the community. The recommendation by many entities, including the CDC, is we like to see the percent positive of the tests we do being below 5%, possibly being a threshold that we should shoot for. However, I would say as long as the virus is in the community, as long as over 90% are susceptible to it, I believe, unless we get a vaccine that's proven to be effective, The mask is the most important thing we have to limit the spread of this virus and people from getting infected and people from getting unnecessarily severe illnesses and death. So I know that's probably not real popular, but I'm afraid the mask is here until we have an effective treatment or vaccine that is proven to be effective in protecting people.
Thank you, Dr. Mintz. To continue on the threshold question, there was a question that came through. What COVID-19 positive test data threshold will you need to see in order for you to support no more mask orders in Sedgwick County? What data threshold is needed for you to support relaxing the gathering limits? What data threshold is needed for you to support relaxing the mass gathering limit?
So again, I don't believe the mask order will be rescinded until we have a treatment or a vaccine is truly effective and a large portion of the population has received it. The other things, the mass gathering size and all that, as I mentioned, if our percent positive test gets below 5% and we can maintain it below that and the compliance with the mask wearing continues, I think there would be certainly openness to enlarging the mass gathering size as well as the venue size.
Wonderful. Do masks prevent us from breathing fresh air or increase the amount of carbon dioxide we breathe?
Generally, there's really no evidence that it causes either. The experience, obviously, there are times when wearing masks for a long time could be, annoying to people, or they may not like it. But there's large experience from hospitals, surgeons who wear a mask for long period of time in the OR. Obviously, towards the end, maybe they would have a sigh of relief when they don't wear it and they're not around other people. But in general, there's no evidence for either that they would cause a carbon dioxide increase or that they cause any issues with oxygenation. That comment is really for people who don't have any underlying health issue. If there's an underlying health issue, lung disease or something like that, those are case-by-case issues that the physician can help discern the risk associated with. But for the general non-sick person or someone who doesn't have any health issues, there's really no evidence for either of those.
Okay. With community spread so prevalent, is it too late to control the spread of COVID-19 with contact tracing?
Well, first of all, I'd say that it's unlikely that more than 5% of the population at this time, probably even less, have had the infection yet. So the large majority of our population still has not been infected with this virus. So I would have to start with, that is not the situation today. So what was the second half of the question?
Is it too late to control the spread of COVID-19 with contact tracing?
No, again, most of us have not had this virus, so we need to find those people who are contacts of active cases so we can get them quarantined so they're not spreading it to others, because by far the greatest number of the population is still susceptible to this virus.
Thank you, sir. There's a woman that asked, with school starting, my husband, who's 66, may be needed to pick up our granddaughter from kindergarten twice a week and watch her for up to 2.5 hours. Her school is located in a zip code with a current 4.74% positive rate. What are our best practices for mitigation of risk in this scenario?
I think the best practices are just reiterating the things that we've described already this morning. I think the first is the masking, wearing that face mask whenever essentially you're outside of your home and you're outside of those that you have close contact with on a regular basis that you're sure have not traveled or had a high risk of exposure to COVID-19. So I think given this individual's age, don't know if they have any underlying health issues, but just age alone, and given that he's going to be outside of his home environment, that's a controlled environment, wearing that mask, social distancing within 6 feet as much as possible, and then hand hygiene. Those are the things that we continue to recommend that have been proven to decrease the risk and the spread of COVID. And certainly, this is one of the challenges with this is his granddaughter, and so he wants to be close to her, but can still be in, the same room as folks, but keep, I have conversations with friends, and we're 6 feet apart, and wearing masks. It's something that we've all had to adapt to and get used to keep, each other safe and keep our community safe.
Wonderful. Thank you, sir. With flu season just around the corner, what is it? What is flu season and the outlook for that related to COVID? Do you see any issue with opportunities for testing for either COVID or the flu?
So definitely being attentive to the flu season that's coming is important. I think this year, and the medical community would agree with this, is more important than ever for people to try to get the flu vaccine for several reasons. One is that with the presence of COVID-19, patients, or people, I should say, before they become patients, could be susceptible to get the flu, which could also further reduce immunity, and definitely I would say a worst case scenario would be for someone to have both diseases at the same time, which is a possibility. So flu vaccination is important this year, specifically, in all age groups and in high-risk age groups. One of this is an anecdote and may or may not happen here. We have learned a little bit from the Southern Hemisphere where they've had their winter season, that when people are paying attention to masking, social distancing, hand hygiene, and being attentive, actually they've had a less severe flu season, which is encouraging, which proves that taking those measures do help. But this year, one of the things that people can do to help themselves and help their communities is to try to get a flu vaccine.
Wonderful. Going back to testing a little bit here, what are the differences between rapid tests, saliva tests, and rapid saliva tests?
I can try to explain this, and if this might take just a minute or so to explain, because I understand the confusion that can come around some of the terminology, specifically when words like rapid tests are used. A PCR test is what is considered the gold standard, is what we use. It's a very good test, and it's very specific. When a sample is obtained, what that machine is trying to do is trying to detect a piece of genetic material that it belongs to COVID-19. That genetic material does not belong to any other virus. It's very specific to the COVID-19. I describe it to people when I try to explain it like a little piece of Lego trying to find a match. And when the sample is obtained, the inside of the virus, the machine is trying to locate that piece of Lego and detect it. And once they do, you pretty high likelihood that that's truly the virus. That's the PCR. That same detection mechanism could potentially be used on saliva. The question is there enough virus in the saliva versus in the back of the mouth in order to do that same detection using the piece of Lego? And that's what gets studied, and eventually we'll find out more. Hopefully, there's very hopeful news that saliva, yes, contains potentially the same amount of virus as the back of the throat. There is another blood test that people sometimes have heard about. Whenever someone is exposed to a virus or any other bacteria, they generate a certain amount of immunity, and these are molecules inside the body that help fight the infection. The challenge with trying to measure the blood test for those molecules is that experience so far with COVID-19 have shown that they're potentially not as specific. They don't always show up in everyone. They may show up in someone, but they are not high enough for the lab machine to detect them. They have their use, and a medical professional could determine when they can use them. But that's why those blood tests are typically, so far, not been relied on in every case. There's a new test that's coming out, and that one is not trying to detect the genetic material. It literally tries to detect a piece of protein that sits on the surface of the virus. That hasn't been widespread yet. It's kind of early in the development stage of that particular test, so there's not a lot of information about if it's good or not. I mention all of these because it's important for people to know the differences. Definitely the PCR that is being obtained, or the genetic material type of test, is the best. It is very specific for COVID-19. The word rapid is really only a reference to how fast does it take for a particular brand of machine to give you a result. Some machines give you a result within maybe 15, 20 minutes. Some machines are just maybe more sophisticated. Their technology is built differently, and it requires several hours. But the underpinning mechanism to detect that genetic material is typically the same between them. It's just how they did design it to give you a result faster enough. That's it. Sorry for the long response.
No, we appreciate it, sir. Thank you. Paul, did you have anything you want to add?
No.
Okay.
I might add, again, I want to emphasize whether it's rapid or not is different than what it actually is testing.
Mm-hmm.
There are PCR tests that are rapid, but they're not equipped to do high volume testing. So most of the major labs don't use it because they can't put very many specimens through at one time. Some of the hospitals actually have the rapid test, but they restrict its use to particular patients that they need to know right away. But for general screening of the population, they're just too slow to
They're
be
not doing
doing.
rapid testing. Okay. Thank you, sir. This is an online question that we got. How can anti-mask and misinformation be stopped?
I think it's through venues like this and continuing education of the public around really what is the science around what we know to this point, and what we've shared this morning, the three of us, I think is what we do know and has been proven through scientific research in the medical community over the last 6 months, and not only in the United States but around the world. And the overwhelming evidence does support the universal masking, the social distancing, and hand hygiene we should be doing all times of the year, whether we're in a pandemic or not. So I think we talk about the science and leave the politics to others to deal with, but certainly the evidence, as scientists, as physicians, we feel very strongly about that, and just want to continue with that message as we message to our own staff at our facilities, to the city, to the county, to the state, and others that will listen. That we're going to be. I think we've been very consistent in that message, and we'll continue to do so.
Yes, sir.
I might add, the medical literature is usually very accurate because the research and stuff that's published has been peer-reviewed and vetted very intensely by physicians who are not involved in the study, that are unbiased. And so you can put a lot of stock in that. I caution people to take advice from social media or the internet, which is totally unrestricted, unreviewed. You can post anything you want on the internet or social media, and no one checks it out to see if it's accurate or not. So I would say pay attention to the stuff that has been subjected to scientific review by a broad audience of scientists and verify that it is accurate.
Dr. Mins, I think to kind of follow up on that question, where should people really get that information? Are there publications or articles that they should be reading? Where should they actually go to actually get that information, in your opinion?
Well, I would say for most people, they should rely upon advice from their physicians and healthcare providers. They can certainly, most of the medical literature is out on the web through the Library of Congress, so they can go there, but some of it's fairly technical and might be hard unless you have experience in that area to really know how to interpret. But again, I think your physician is a good place to go.
Wonderful. Thank you, sir. Continue on the mask portion. This question asks, is it important to mask until a vaccine is created?
I think we've already touched on that. Until we have a vaccine or treatment, the only tools we have to prevent this virus from infecting people is the social distancing, the mask, hand washing, and all those things we're doing now. So I'm afraid if we stop doing those things, the virus is still out there, most of us are susceptible, and the numbers will just go back up, which we learned happened at the end of May, when none of this was enforced, or none of it was even thought to be important by most of the people. And I'm afraid it'll just happen again if that's the case. I use the analogy, if you're in a Indy 500 car race and you're in the lead, you don't take your foot off the accelerator because the rest of the crew, they're fighting to get ahead of you. So the virus is the same way. We're in a battle with the virus, and it'll take advantage if we stop doing all the social distancing and all that. It'll take advantage of that and just come roaring back.
Yes, sir. Is it important? What is the right age for requirement of masking? Is there an age? Because I know we heard 5 didn't have to wear a mask. So is there an age for the requirement of masking?
Well, in terms of, doing a little bit of research, looking at the CDC guidelines around this, and there is some difference of opinion as you look at some of the governing agencies. But for the United States and the CDC, recommendation is for children that are 2 or older. So basically anyone that is 2 or older that has no physical limitations or medical reasons not to wear a mask. The recommendation is to have those individuals utilizing a mask whenever, again, they'd be out in public or be potentially exposed. The WHO, I believe, they look at sick. I think it's 5 years of age is where some of their recommendations. But I think we were just speaking just before we went live this morning. Our pastor was commenting to and commending the parents in church for their children wearing masks, and so I've seen children at the hospital too going through with their parents, and they're 3 years old, 3-4 years old, and they're wearing masks. Certainly for babies and children under the age of 2, it is not recommended because of the potential for suffocation with that child. They may not have infants don't have the ability to take the mask off, or the young children. So you certainly do need to have a level of consciousness that if you need to, you can remove that mask if it was causing some issues. But that's the recommendation at this time.
Yes, sir.
I might add, again, we've only had this virus in our country for 6-7 months, so there's still a lot of unknowns about it. We've only had the chance to do research on this virus for the last 6 months or so, so we're still learning a lot. One of the big controversies we have, or big mysteries we have, is why children don't seem to get very sick with this. A few do, but they don't seem to be as susceptible to this virus as older individuals. On the other hand, we're not sure yet how much they transmit the virus, even though they don't get sick from it. In some respects, they may transmit it better because they don't get sick. People don't think they have it. They don't even know they have it. So there's still research ongoing about how well they transmit it, and we're still learning. If we find out that they do transmit it pretty well, we probably will continue to recommend highly they wear a mask. But at this point, we're assuming they can transmit it, so we're recommending the children wear the mask.
Thank you, sir. This is a 2-part question. Once you get tested for COVID, do you have to isolate for 10 days? And what about retesting?
Well, if you're a contact of an active case, a close contact, we test you to see if you already are infected with it, and if so, we have to isolate you. If the test comes back negative, we need to quarantine you because you may be in the incubation period. So we will quarantine you for 14 days, which is, we think, the longest period the incubation period is likely to be. So either way, you're probably going to be quarantined or isolated. So it's still important. That's what we do. That's why we do contact tracing, to figure out who already has infected because you had it and you gave it to them. Or if they're not infected at that point, they're still could be too early to detect it. And so you need to be quarantined until we can make sure you've spent 14 days without any signs of illness before you can go back to work or school or out in society.
Okay. If a person has been tested and already has the virus and now has the antibodies, does a mask need to be worn after recovering from the virus? If yes, why? If no, then a lot of people no longer need to wear one.
I'll try. I'll certainly be interested in what my partners have to say. Again, if you've had it, we think, and you recovered, we think you have antibodies, and we think you're immune, although there has been some recent research identifying an individual who apparently has gotten it for the second time. So there's still, again, we're still early in our understanding of this disease and individuals' immunity. So we don't have real good evidence yet how well you're protected by having had it once and how unlikely or likely it is you could get a second time. Don't know yet. So I would say at this point, until we know more, you probably should just keep wearing the mask because, again, we've only had this virus 6 months. We still have a lot we need to learn about it, and I think it would be an assumption that you can't get it again.
Yes, sir. What are the speculations for vaccines and or treatment, and what is the best evidence for transmission?
I think, I don't know if everybody has been kind of following this in the news, but there are several companies, actually quite a few, that are heavily invested in finding a vaccine. Typically, vaccine generation is something that takes many years. The encouraging thing about COVID-19 is there's been intensified research, there's been intensified investment, and so as a result, a lot of companies are ahead, and I think there's at least a couple of dozen biopharmaceutical companies that are invested in this, and there's a few even that have reached what's called a level 3, the third level, just before you kind of find out a little bit more information to see if you receive FDA approval for the vaccine. So that's encouraging news. Because of the amount of attention that's being placed on this area of research, I'm optimistic. Obviously, we can't tell until the data is published. Typically, they will give the vaccine to volunteers and evaluate their response, evaluate for side effects. They sum up all that data, they submit it to experts, and they go through a process of then approval. So I don't have any additional information because there's a lot of promising companies that are doing pretty impressive work in the short amount of time that they've had.
So just to help me understand, so after stage 3 is when the company gets FDA approval to then release the vaccine?
They have to collect the data correct, and they need to have everything summed up and then submit it for approval.
Okay.
So phase 3 is to show it's effective. Phase 1 is meant to show if it's safe. But they continue to monitor safety and even into phase 3. So they have to complete phase 3 and show the data that this vaccine really does protect the individual. If it doesn't protect them, FDA is not going to approve it. But it takes usually months to get enough people vaccinated and to see if it helps prevent them from getting it before we know for sure whether it's protective or not. I think there's been some speculation, if everything goes exactly right,
Which never happens.
if everything were totally work out perfectly, that probably maybe sometime in 2021 we might have a vaccine. Now, some people have speculated maybe even earlier, but I think most people I've talked to, including I've seen interviews with the NIH director and others, earlier than that is extremely optimistic, extremely. Now, the other thing we need to realize, there have been instances in the past where a promising vaccine turned out to cause side effects that were not acceptable. And that's another reason we need to study it longer because, I think everyone's aware there's some vaccines out there that in the past have caused big trouble, and so they were taken off the market. We don't want a vaccine that causes trouble.
And I'll just say that even though 2021 seems like such a long time from now, given what we have been dealing with, but if you think about the fact that we started dealing with this just in 2020, if there's a vaccine by 2021, even if it's towards middle or even end of 2021, in comparison to historical timelines of how vaccines have generally been developed, that is still pretty good. Because a typical vaccine takes 10, sometimes even 15 years before it's completely developed, completely researched, and all the data. So the fact that there's enough intensity and kind of with the caveats that Dr. Minz has mentioned, that there's always potential side effects and all of that, for it to be in 2021 is still actually an accelerated short timeline.
Okay. Dr. Eversole, did you have something?
Yeah, there are 3 vaccines that are right now currently in the U.S. in large clinical trials. And you know what I think you're hearing from the 3 of us is a kind of guarded optimism. You know, we're very encouraged by what we're seeing with the clinical trials, that several are in these phase 3 already. But we, you know, to just reiterate, we have to make sure that this is safe. You know, that it's efficacious, in other words, that it does cause an immune response and increase in antibodies, but then in addition that it is safe, because this is going to be a vaccine that we want to make available for worldwide, you know, not only our neighbors here in the United States, but we want to, you know, be able to distribute this through the world. So we'll continue to watch with a lot of optimism, but also approaching again from that scientific respect to make sure that it is as safe and something that we feel comfortable, you know, that I can feel comfortable giving to my own family, to myself, of course, to our colleagues at the hospital, who, you know, we just want everybody to remain safe during this time.
You know, Dr. Eversole, to kind of follow up on that, the worldwide piece, we've seen a vaccine being given to those in Russia. What are your thoughts about that vaccine? Because I think some people would then ask, how come we're not receiving that same vaccine?
You know, what I can only say is we haven't seen anything published about that. And if you try to research who developed it, how, what are mechanisms, the biology behind it, it's not available, which makes it very difficult to formulate an opinion about that. Makes you a little bit maybe cautious to how you interpret it one way or the other, given the fact that there hasn't been any public information or even in the medical literature about it from Russia. So it's hard to tell. It's been, yeah.
Perfect. We have an online question here. What are your thoughts on so many asymptomatic people but not testing folks if they have no symptoms? Are we really getting an accurate vision of the numbers and the spread?
It is one of the mysteries of this virus and this disease is why it can be so severely, cause such severe illness in some people, but in other people they carry it around, they don't even know it. So we're still trying to figure out what's the difference between those 2 people. In our drive-thrus that we're doing right now, we occasionally find people who are asymptomatic and are positive. But right now we've not had the capacity, and I think as the public knows, we've had a real struggle having enough tests available even to test the symptomatic people. At some point, if we have adequate testing availability, maybe we could do more asymptomatic testing, but up until now, we've just barely had enough testing capacity to do the symptomatic people.
Okay. What do we know about long-term health impacts on the heart, the lungs, kidneys, and liver for patients?
Just real brief, I'll make a comment about what we do know. There's still a lot that is maybe we don't have a lot of information about. Some of the stuff that has become a little bit more obvious are around the heart impact. And this is something that we certainly have seen cases of here. There appears to be in some patients, not in everyone, an inflammation, so to speak, that attacks the heart and that causes either heart failure or other problems with the heart that is related to COVID-19. It is well described now. There's research and reports about it quite a bit. As far as the other organs of the body, you always find case reports. There's been description of skin involvement to some degree. It seems to be a little bit more mild. And we do know that we consider, the blood vessels to be their own organ. There is clotting that occurs sometimes, so the virus causes the blood to be thicker and some clotting that occurs. Mostly venous, although there's sometimes been other types of clotting in vessels. There's been few case reports, so these are not very frequent, of inflammation that attacks the brain. But I would say the ones that have become fairly frequent and reported systematically are the heart impact.
I would just add, in terms of for the lungs, there's been some pretty dramatic cases and a lot of research and literature around the COVID patients that, particularly in the ICU, that have had acute lung injury from this, as well as, and this is what we don't know, is what is going to be the chronic effects for these individuals because of their damage to their lungs. We do know for some of the earlier cases that maybe they had it early on 5-6 months ago. Some of those patients still they're not back to their prior level of in terms of their lung capacity, ability to exercise. Some patients that we've had at Wesley do require prolonged use of oxygen. So there's a lot, as Dr. Antonius was saying, a lot that we don't know. But certainly with COVID has some very significant effects, or can have some very significant effects on the lung. Some of these patients, our ICU patients, do require actually mechanical ventilation or a breathing tube. Fortunately, we've had less of those cases. We're using more high-flow oxygen and some non-invasive, basically like a mask or a CPAP to provide oxygen. And we're intubating or putting a breathing tube down less of these patients. But I think the great unknown, like so much of COVID, is going to be what are going to be the chronic effects on patients from this disease.
Yes, sir. So this question kind of follows up with what your response was, Dr. Ebersol. How are local hospitals doing right now? Are they overloaded with patients with so many confirmed cases?
So we are not overloaded. We have had a steady number of COVID patients, particularly, as Dr. Mins alluded to a few minutes ago, kind of going back to May, and about 3 weeks after that, beginning in June, we've had a very steady number. It does ebb and flow. Dr. Antonios can speak to their facility, but we talk almost every day of just knowing where we are as a community, and also communicate with the VA hospital so that we know where we kind of are from a community perspective. We have dedicated, COVID units that are isolated and to protect our patients, to protect our staff and physicians. That those patients are tested in the emergency department or prior to coming, so we know their status and we can cohort those patients. And it's evolved in terms of the treatment, as I was describing a few minutes ago, but we have good capacity for the care of these patients. Our PPE supply chain is very solid in terms of the number of ventilators that we have for these patients, and that usage has gone down, fortunately, but in a really good place right now.
Dr. Antonius, did you want to add to that?
No, we've seen obviously in this early in the summer, late spring, we had seen the lowest number of patients in the hospital. Since then, there has been a steady increase in the community of active cases, as everybody knows. What we notice is that the number of hospitalizations kind of go in parallel, and they follow the number of active cases in the community. Thankfully, over the last several weeks, it has stabilized. It's been hovering kind of around stable numbers. We obviously prefer if we have not as many sick people who require hospitalization for the sake of the health of our community. It would be nice if the numbers could go down to the way they were in the summer, but so far it's been kind of stabilized, and we're doing okay. I did want to take, actually, since you asked about the hospital, I do want to take an opportunity just now to say thank you to all of our really dedicated nurses, doctors, respiratory therapists, and everybody, all the other staff. I don't want to miss any specialty or anyone who are working very hard day and night to take care of COVID-19 patients, and they're doing it selflessly, and they're putting their hearts out there to help those patients. So just a shout out for our team.
Yeah, and I'm sure Dr. Ebersol.
So I'd like to add that it's not just the number of patients with COVID. Both hospitals have had some instances where their staff has gotten infected, and that means they have to be removed from the hospital until they're recovered. And that has caused sometimes some staffing issues that they have to deal with. So it's put a heavy strain on the hospitals. And as was mentioned, the number in the hospitals tend to follow the number in the community. And so over the last 8 weeks, our community numbers have come down, thankfully, because of the mask mandate, I believe, and other things we're doing, and that has helped out the hospitals. But again, if we discontinue the mandate of the mask and all the other things and just go back to, quote, normal, I highly anticipate the numbers in the hospital will be going right back up.
You know, Dr. Ebersol, you kind of mentioned this briefly. I think it's important to note as well that there are a lot of conversations being had in our community, right? And so every Monday, yourselves as well as the VA, Sedgwick County, City of Wichita, those elected officials are talking. Could you kind of give me just a brief idea of kind of some of the things that you guys talk about and kind of the importance of that call?
Sure. I think the biggest thing is it's a sharing of information. So Wesley Healthcare's CEO, Bill Volich, hosts this call, and just he's just there to facilitate, to communicate our numbers so that we all really know kind of what it, as a community, so individually how the health systems are doing, and then as a whole, how are we doing as a community. And so we share those, numbers, and then we can track and trend kind of where we are, again, as a city and a county, and then open it up to, just some discussion. There are often questions from our county and city colleagues, depending on kind of how things, what happened that week in the community, whether it, may have been some, one of the orders from the county or the city. How's that affected? What are we kind of seeing as we went through the summer? When things were opened up at different times. What is the effect of that we're seeing at the hospital? And it's usually there is a delay, but as Dr. Mins was saying, there is definitely a relation there, a relationship between community cases increasing, that community spread, and then what we see at the hospital. But I think the biggest benefit is just that sharing of information between each other.
Kind of staying on the hospital side, this question asks, in the beginning, we were not to overwhelm the hospitals and keep the numbers down. Why has that criteria changed? What numbers are being used in testing equipment used by Sedgwick County to validate a yes for positive? This is a long one. What are the numbers for the positive people? Will you please make those numbers available to the county commissioners and to the public? So I think that's really on my end, an earnest on my end. So I think maybe the question to you all is, why has that criteria changed not to overwhelm the hospitals, or has it changed?
Well, I don't think it's changed. We look at many metrics. We look at the percent positive of all the testing we're doing, but we also look at the hospital numbers. We look at the big picture to decide how we're doing in the community. And oftentimes, as we mentioned, the number of cases in the community tends to mirror what's going on, the number of cases we see in the hospital. So we try to look at the total picture of how this disease is affecting our community in terms of people off work, out of commission, as well as those who are in the ICU and in the hospital.
To answer part of your question, what are the numbers for the positives? And I mean, maybe this particular question came from someone who doesn't know this, but the Sedgwick County Health Department has a website that is listing positive results of PCR and all of that. So, I mean, I guess I would refer to that website, which is a pretty well done website with graphs and progression over time of the numbers.
Thanks for that plug, Dr. Antonios. And so that website the doctor's talking about is our dashboard. If you go to sedgwickcounty.gov, you'll be able to pull up on the banner there. You'll see COVID-19, and it gives you the most up-to-date information related to COVID-19 numbers, questions, concerns. We have Q&As on there as well for you all to pull from.
And that information is available to the county commissioners at all times.
Absolutely. Absolutely. And they're constantly talking about it on a daily basis. So thank you. Is this virus being treated like a vaccine? Why or why not? And I think we kind of touched on it a little bit earlier, but if you guys want to kind of touch on that again.
I'm not sure. The question is this virus being treated like a vaccine?
Yes, sir.
I'm not really sure what the question is, but the virus is the virus that infects us and causes the disease. The vaccine is something we're trying to develop that would help our body fight off the virus before we even get diseased with it. So just like we get measles vaccines, so that if we get exposed to measles, we don't get measles. So vaccine's separate than the disease.
Let's see. We've got one regarding the PCR test sample amplification issue. Is it possible to test positive and not be contagious?
I can try to answer this in the least amount of technicality as possible, but the answer is yes, it is possible to sometimes test positive and not be contagious. There's been described in the literature that people who have tested positive have been retested several weeks later and they have remained positive. And that goes back to what I explained earlier about what does it mean to have a PCR, is you detect a piece of genetic material, a small piece of genetic material that belongs to the virus. Occasionally, what happens is the virus itself would be dead, but little fragments of that genetic material remains inside someone's throat. And so when you run a second test several weeks later, it would come back as positive because you did not detect at that point the virus, you detect those little small fragments that have just remnants or remaining. They're there. Those very specific cases are potentially non-contagious. The challenge comes with if it's the first time you ever get tested, you don't know if you're dealing with a new infection, someone who just now has the virus and remains contagious, or we're dealing with this person who has now recovered, what we probably would call a recovered person, and there's just small fragments of that genetic material remaining, which eventually goes away. So it's a little bit of a technical answer, but that's kind of what the explanation is.
So until we know more, have more research, we have to presume if you have the virus positive by the PCR test that you are infectious. Now, further data and research may prove that some people aren't, but we can't assume that at this point. We don't have enough information.
Yes, sir. We've got about 8 more minutes now. So just a few more questions, and then we'll allow you guys closing kind of statements if you'd like. If someone tests positive and gets retested for a negative in order to go back to work, is that double dipping and throwing off the data? So a positive test, and then you later test negative to go back to work.
Dr. Mins might know the answer for this, but my understanding is that typically there's a name attached to a particular test, and so a name of a person, and so another test refers back to the same person, so it doesn't get double counted. But I don't know if that's how at least that's how it works for our hospital. So we don't double count a patient when they get retested because we go by the name, not by the test.
It's a very special and unique situation where we'd even do that. Once we have a positive test, we do not generally test again. And if we did test, we'd have to adjudicate that on an individual basis. But there would have to be specific reasons to even test again.
And this, yeah, related to that, the CDC guidelines actually changed on the recommendations, in late July around retesting. They recommended moving from what had been a test-based strategy of retesting, and I'm speaking more to kind of the acutely ill, kind of our world in the hospital, of testing some of these patients to a symptom-based strategy. So it's really more, once you're positive and then you quarantine, for that period of time, the thought and the evidence is that, your viral load is so low that you're not contagious anymore. You're beyond that 14-day period. And again, you can retest. If you retested, you may, as Dr. Antonios has described several times, there may be a little piece of that genetic material, a little piece of that RNA that the PCR picks up on, but that's really doesn't indicate that there's any active, disease at that time.
Okay. What is counted as a COVID death? Is respiratory failure from the virus counted as a COVID death?
In our hospital, we pay attention to what is attributed to COVID-19 death, and it's a condition that has only existed as a result of the patient getting infected with COVID-19. And most of the time, when it comes down to cases of death, generally it does involve a pretty significant respiratory failure. People are generally on a ventilator. Obviously, there's always exceptions, but it's the condition that has been precipitated directly as a result of an infection of COVID-19.
Okay. We've got another online question here. What do you think the country or the world would look like if everyone stopped wearing a mask? I know that's kind of a worst-case scenario, but...
Well, I think I've already addressed this. If we all just stop wearing masks throughout the world, there is no reason to think the virus will vanish. And I think the number of people being infected will expand rapidly, and I think our hospitals will be overwhelmed. And so I think if you look back at what New York looked like earlier in the year, that's the way every city would look.
Okay. Sure.
It's a world that I don't want to really think about. It could very much overwhelm, as Dr. Mins was saying, our hospitals. We have contingency plans, but if the virus is left unchecked, it will spread rapidly and could easily, overwhelm the capacity of even our two large health systems here in Wichita. So, we have planned, and those plans remain in place, and we have capabilities to flex up and serve our community and treat our community, but there are even limitations to that. So it's a world that I don't want to, would prefer not to even think about or certainly experience.
You might, if they're really curious, they might go read the book about the 1918 flu. Back then they had no viral tests. They weren't even sure what it was. And that killed an amazing number of people.
Thank you, sir. This kind of brings us to a conclusion. We, just for the public's knowledge, we had more than 50 questions that we received. And I think today we got to quite a few of them with great discussion and insight on the path forward. So now we've got a couple of minutes. So if you guys want to take a few moments just to kind of give a closing statement to folks who are watching today. Dr. Ebersol, we'll start with you.
Sure. Well, thank you again for the invitation to come speak and answer some questions this morning from the public. And just want to reiterate the three things that we've been kind of talking about quite a bit is around the universal masking, social distancing, and hand hygiene, because that is really been the proven things to protect each other, to protect our community. So just really want to encourage people to continue to do so, to encourage others, that you may see, and just seems like a fairly simple thing to protect, the ones we love and those brothers and sisters in our community to wear that mask and respect each other with that. So just appreciate all of our healthcare workers at the whole city, our frontline workers, our EMS. Sedgwick County provides all the EMS and services, and they're those, they're really the ones first on the scenes and putting themselves in harm's way as well as they bring those patients into our emergency departments to be evaluated and treated. So just thank you for that, and thanks for the opportunity this morning.
Thank you, sir. Dr. Antonios?
Yeah, thank you for the invitation to come here and help answer some of these questions. I hope we have answered as many as we can, and at least technical possible ways. Sometimes we doctors can use a lot of jargon, so I hope we can do a lot of that. And I just wanted to say a couple of things. With some adaptation, we can learn to live with the virus until there is a solution, such as a vaccine, which I'm hopeful for. We have to remember that we live in a community, and so we are looking out for each other, specifically the vulnerable. We're looking out for people who may get negatively impacted by the virus. So just to keep that in mind as we're trying to interact with others, and this is why we try to avoid the spread. I did want to send another salute, another shout out to our teams, who I'm very proud of, and they're very dedicated professionals across the city and specifically within our hospitals and clinics. And thank you for all of that they do. And the last comment is for people to not be scared and to try to live their life, and specifically not avoid medical care. We didn't touch base on here, but we have seen, unfortunately, some impact of people avoiding going to their physician or going to the hospital, going to the clinic or ED. And delaying care is not worth it. So I just want to make sure people continue to seek help for their healthcare needs. Thank you.
Thank you, sir. Lastly, Dr. Mintz.
I just thank everyone for their questions. I hope we've helped people understand a little bit better. And if it has been helpful, I think we would entertain doing it again at some time. I think it's important to get information from people who study this and know about it. And again, I would caution people to pay too much attention to social media and the internet, since none of that is vetted at all. And I also want to thank our hospital partners. If you compare our death rate in the Sedgwick County compared to the other major metropolitan areas in the state of Kansas, we've had a fairly low death rate. And I want to give kudos to our hospital and our healthcare providers. And I think that speaks to the quality of care they've been getting. We all need to be partners in this. If we're all partners, we can lick this virus.
Gentlemen, thank you so much. And thank you all for watching today, and for everyone here at Sedgwick County. If you have questions related to COVID-19, you can still ask those questions using social media or communications@sedgwick.gov. We encourage you to get onto the sedgwickcounty.gov website and click on that banner that says COVID-19. You can find all of the up-to-date information the doctors are talking about today. Again, thank you.